Hey, everybody. Can you hear me?
Yep,
Yep.
we can hear you.
Oh, okay. All right. How's everybody doing this morning?
Good, great to see you.
All right, great. Yeah, so I'm Raj Patel, and this is Dr. Naveen Gala, Dr. Ricky Croft, and everybody knows Dr. Patel here, Rahul Patel. So, Dr. Gala, go ahead. Start with this next case,
Great.
please.
So hi everyone. So I'm Naveen Gala, one of the PGY6 IR residents, and I'm doing this case with my attendings, Dr. Rahul and
You'll
Dr.
go ahead
Rajesh
and mix it.
Patel, uh, and my co-resident Ricky, our nurses Ali and Catherine, our anesthesiologist Matt, and our techs Bell and Andrew. And so today we're presenting a case of lower abdominal and pelvic pain heaviness. Next slide. So our patient is a 63-year-old female postmenopausal. She's had 2 prior pregnancies. She presents with a 4-month history of intermittent lower abdominal and pelvic pain and heaviness radiating to the back. Her pain is described as more prominent on the left side and worse at the end of the day. She describes it as lifestyle limiting pain, requiring prior visits to the emergency department. And she's being followed by her OB, and she's been started on Lupron without any symptomatic improvement. And she was referred to Dr. Patel for evaluation for possible pelvic congestion syndrome. Next slide. We saw her in the office, and in terms of her past medical and past surgical history, it's notable for his prior C-section, myomectomy. Labs are unremarkable. As described, she's on Lupron. She's also been treated with NSAIDs and Tylenol without improvement. Her physical exam is notable for lower abdominal pain with deep palpitation, and her pelvic exam is negative for any vulvar or labial varicosities. Next slide. So here we have a axial and coronal CT imaging. As you can see on the axial imaging, we have 2 bilateral dilated gonadal veins and myometrial plexus veins here on the left, and then the coronal images on the right. You see bilateral dilated gonadal veins. And here's just an MRI showing no uterine pathology, no pelvic lymphadenopathy. And they also mention non-specific prominence of the gonadal veins. Next slide. So our plan for her, so she's a 63-year-old female, postmenopausal, with clinical symptoms and imaging findings of pelvic congestion syndrome. And given that she has significant symptomatology despite medical treatment and imaging findings of pelvic congestion syndrome, the patient was offered endovascular intervention for alleviation of the pelvic symptoms. So today we're planning to do a bilateral gonadal venography and possible sclerosis and embolization.
Right. Can we go to the fluoro?
And these are just some of the procedural considerations we'll be discussing today.
Okay.
The floor images.
Can we go to the fluoro now? Okay, so we had jugular access, and we put in a 7 French sheath here, and this is our initial left renal venogram with a Cobra catheter. And you can see that just with a simple hand injection, there's a fair amount of reflux into the left gonadal vein. Right. Let's go to the next one. Yeah. So we were able to manipulate a wire down into the left gonadal vein, and just a little hand injection here first. And you can see that there's already opacification of the ovarian plexus on the left side, as well as the uterine plexus, with some opacification over to the right side. This is without the balloon. And then we put in a python balloon here, and put the balloon up, the occlusion balloon, and we did a run through the balloon. All right. So what does everybody think of this?
That's an impressive venogram. Just with the hand injection in the renal vein, you're getting a remarkable amount of reflux into the gonadal vein.
Yeah, yeah. Can we go back just a tiny bit for that one? Yeah, yeah. Just with the late part of that run. Great.
So, a few things to discuss real
Yeah.
quick.
So. Uh-huh.
Um,
Yeah. Please.
the age of the patient. We typically hear that female pelvic venous disease is more of a, premenopausal thing. And I can tell you, I'm with you guys. I've seen it affect older patients. It's not as common in postmenopausal, but it does occur. What's your guys' thoughts on that, and sort of the frequency with which you see older patients continue to have pelvic symptoms?
Yeah, I mean, it's been my experience that I find that most of the patients are actually, perimenopausal, basically older. They're usually older than 45. And many of them, as we hear and we learn, many of them actually have had symptoms for many years. They get really sort of underdiagnosed, misdiagnosed. It's not until somebody, who's caring for them says, hey, look, maybe we should get a CAT scan. And then once these prominent collaterals are seen, maybe in a CAT scan or an ultrasound, we decide that, oh, okay, look, this is possibly a pelvic congestion syndrome. So I do think it does go relatively unrecognized, and even especially in some of these older patients. But yeah, I agree that I think even postmenopausal women, it's wise for them when they have these vague symptoms, obviously, to have a workup.
Seems she had a pretty
So,
extensive imaging workup. Can you just talk about which one you rely on the most for these patients, whether it's the ultrasound or
Yeah.
MR?
Yeah, so as it turns out, the imaging for this patient was actually obtained by one of our GYN physicians. And, obviously we have a close working relationship with them. And so, he had already gotten the CAT scan. But the CAT scan actually that was showed, it was a year and a half old. So actually she didn't come to me until the GYN actually got the MRI and then decided, wait a minute, there's not much pelvic, uterine pathology and just these prominent veins. And so that's when he sent them to us. But usually, they've already had an ultrasound. And so I usually, if I suspect it, I usually will get a CT. I think it's reasonable to get an MRI of the pelvis with a MR, venography of the abdomen and pelvis, and so that's another way of doing it. But I do think it's important to actually make sure there isn't any other uterine pathology, especially in these perimenopausal or postmenopausal women.
The CT actually.
Is somebody using something else?
No, we agree with you. Dynamic MRI
Okay.
is something we use, but the CT actually gives you your answer. You have dense contrast in the ovarian veins. It's way denser than the rest of the venous blood pool.
Yeah.
So it's clearly refluxing and static there.
Okay, good. So we're putting our balloon back up. We had it down for a little bit, and just before we start, or just we're going to be using STS here. We're going to be using some of STS foam along with some thiodol. So go ahead.
Okay.
Why don't you go ahead and open that up, and we're going to start here. Only just this because for the sake of time, and also because this is actually
Yes, right,
opening
okay.
up.
What are you foaming with?
Just want to
Air?
make sure. We're using actually CO2
CO2. Okay.
and STS and some thiodol. Here.
What's your cocktail mixture of each of those components?
Well, I like to use what we are have read about from the BRTO literature. Yeah, it's getting we've had a little crack here because it's been sitting, unfortunately, a little bit. We're going to get another syringe here and make this work. I think we'll get this one too if you like. We usually use. I like to use 3% STS, a thiodol, and carbon dioxide. So I use 3 to 2 to 1. I know that there are some operators that are actually, like to just basically go with nothing to opacify the the sclerosing agent. They just use STS, either 2 or 3%, as well as carbon dioxide. Are people using air also, room air?
I think a lot of
Here we go,
people
we're
do, but
starting
I
to get
agree
it.
with you on using carbon dioxide. I think it gives you a finer bubble, more surface area.
Yeah, I think that I think that overall, I think most people feel that room air gives you slightly different kind of foam. But I do think that the CO2, I prefer actually to give the CO2. Especially if you're going to be giving a fair amount of foam. And if you think that there's a chance that it could go systemically, I think better to go ahead and do that. We're just trying to
What are
sort
you
of,
watching for
work
on
out
this
the-
injection as you inject the foam?
Yeah, so I like to just sort of see that we're seeing where the put your finger on that, yeah, um, that the foam is is opacifying obviously the ovarian plexus and the uterine plexus, and I'm actually looking to see if there's any opacification of the iliac veins. Because if we have that, then I prefer to sort of at least stop for a little bit, and then see what else we're opacifying. Because obviously, as the foam sets up, things are going to change a little bit, and some vessels might start to fill. You might see some opacification of some of the iliac veins, and that's a time to stop. But I'm looking for basically the uterine plexus fill, hopefully fill over to the contralateral side and possibly even fill the, contralateral gonadal vein like it did on our earlier run.
Raj, do you
much
do
have we
your
got in so
injection
far?
from? I see you're doing it from the mid gonadal. Do you go deeper down into the plexus to inject at all, or do you inject from here usually?
Yeah, that's a very, very good question. And actually, I like to be basically, I like to put the balloon catheter, just central to where I can see some of the parallel collaterals. Because obviously, the idea of using the STS, using the foam, is to basically get into those parallel collaterals and reduce the likelihood of, late recurrence, late failure. And so I like to, and so we were able to see that this was one of the larger parallel collaterals just above the level of the iliac crest. And you can see now, I hope you can see it on the screen, that we're actually starting. Why don't we go ahead and just push some out, a little more out of the catheter. You can see that we're starting to fill some of the, release the peripheral aspect of the left, from the uterine plexus right into the right ovarian plexus. Yeah, that's good right there. That's great. Beautiful. Okay. Excellent. All right, you take a single shot?
Yep.
So as I was saying earlier, I like to position it so that we're actually, above some of those prominent, collaterals, those parallel collaterals. I know there's reports. Some people will just go ahead and get a catheter down, maybe even go through the plexus and go into the contralateral gonadal vein, and then use something else like maybe glue or some other embolic agent.
Can you tell
And
us
it's just
why you use a balloon and how do you decide on the volume of sclerosing to inject into the gonadal
yeah,
vein?
that's a very good question. And one of the things that we did here, which I think
Trying to
you may
wire.
have seen it earlier, which is that we had actually, with the balloon up, we had put in some 50-50 contrast, and we were able to actually calculate or at least estimate the volume of the system, basically of the central left gonadal vein and also the plexus and the contralateral vein. So we actually estimated that to be about 20 cc's. That's going. Okay.
There's a
right.
good amount of flow on the right
So
side there.
so yeah, actually it's crept up quite a bit over there, and we didn't see anything going into the iliac system, so I'm actually quite happy with that, because obviously
Yeah.
you can get some new collaterals opening up or venous tributaries opening up, and we just want to make sure that we actually are sort of slowing down the injection, if we're doing that.
It came.
All right, so I
Came
think
out
we're in the process here now of putting in
No, I don't think
a
it came
coil
attached.
here. What does the group think about how long the foam should be left in place?
Yeah, I think that's the variable part. And so what I personally do is I wait to I don't use an occlusion balloon. I think that's totally valid to do it. It's a personal preference. And then I wait till the pelvic reservoir is basically obliterated. And then I have a very loose coil pack on the way out.
Okay.
Yeah, why do you keep it loose?
One, cost, and two, you often have reflux. When you do it without an occlusion balloon, you get a lot of reflux up your ovarian vein. So the sotrodecol beats up the vein to begin with, and it's already started to thrombose, and the coil just finishes it off.
What coils are you using?
Okay. We're using a interlocks here. Yeah, these are the 35 interlocks. We also have some, some pushable coils here, some 35 nesters. I think one of the coils has it's gotten a little stuck here. So do you, okay, yes. So, do you feel, Chris, do you feel that, not having the occlusion balloon, that actually, does
Can't hear you.
does help,
Can you turn your mic set off?
fill the plexus more? So I just feel like you might get a little bit better filling if you have the occlusion balloon, which is
Ye-
why I like to use it.
Yeah, so I think part of it is that I park the catheter pretty far down. So
Okay.
if in this image, it would be like at the bottom of the SI joint roughly, and it'd be like a 5 French angle to
Okay.
the catheter. And then you're right, you get parallel pathways closing, and I'm the same as you. I look for the iliac vein. I look at my runs, and if I see the iliac vein pop up, I note the amount of volume that I've injected, and then I inject less foam sclerosant than that volume, so it's not, in theory, going into the iliac vein. And then what I typically see is that the whole left side and most of the plexus gets beat up, and then I catheterize the right
Okay.
side. And on the right side,
Right.
you have very little left to do, but you close a little bit of the reservoir on that side, and then just a couple coils, and then you're done. But again, there's a lot of different ways to do this.
Yes, no, okay. I think there is. I like the balloon mainly because I feel like we can fill out the plexus. Get some more of the collaterals. Prevent some of the sclerosing agent from being driven by the reflux into veins that we might not want it to go to. So I like the balloon to sort of help modulate the flow. But but you're right. There are a lot of different ways of handling this.
Okay.
Yeah.
Okay.
On
So
the
we're just going to
balloon
be getting
run,
a coil down.
sorry,
Uh-huh.
sorry. On the balloon run, you saw that contrast ascend the right side. So are you ever worried that you'll drive the sclerosant systemically from the right side?
Well, yes. I mean that's one of the things that we saw some earlier, and then actually it sort of stopped, and I think it got driven a little bit back down, by some of the reflux. But yeah, I mean, obviously when we're seeing some sclerosing agent, getting close or being driven systemically, that's when obviously we want to stop.
So what was your endpoint
Very-
here to determine that you didn't need to put more sclerosant in? Because I think that's the tricky thing, that as this therapy develops, and we're going to be going into a randomized trial with the embolized trial that SIR and industry is going to help support, is trying to get us all to do it in a similar way so it's reproducible. And so that's one of the things that is inherently variable. When do you stop sclerosing? What volume do you use? That kind of thing.
Yeah, I think here we had seen that we had filled most of the really all of the plexus, both the ovarian and uterine plexus, and then we're getting filling in a retrograde fashion up the right side, and that was at 20 cc's, and that's sort of my sort of estimation calculation of how I decide on how much volume we're going to give of the sclerosing agent. So I mix it based on that, so, okay, we had 20 cc's, so I'm going to mix about, about 21, 22 cc's, and we'll see how much we get in. And obviously things change. And once we start to see that there's enough in there, then we'll stop, and then we'll say, okay, this is how much we're able to get in. So, my endpoint is that. But I guess my question also is, why do you like a sort of a looser packing?
I think I think you can use less coils, and I have yet to see recanalization be an issue, just because you're also using the foam that beats up the vein.
Do you think it's more of an issue for varicocele versus, meaning male gonadal vein versus female gonadal vein embolization? In other words, do you feel like the late recurrences, especially with varicocele, those are really related to parallel collaterals that didn't get adequately treated?
Yeah, I think part of it is that we don't typically give a lot of sclerosing directly into the pampiniform plexus for varicocele just because
Yeah.
of the pain and so that part
And
of
just the volume, yeah.
yeah, right, exactly. And so that part of the procedure isn't analogous to the female side, but I think because you're not giving as much sclerosant, you're not refluxing as much into the gonadal vein in a male, and so the risk of parallel channel patency is higher. I mean, this is all just speculation.
It is true that the volume that we typically give for the male gonadal vein versus female is certainly very different. It's much lower. You know, maybe use whatever 6 cc's, 8 cc's of foam, with, two basically different spots for the coils. And so, yeah, I mean, I think that is the case. But I have yet, and love to hear, what people's thought are. I've seen very few of the of female late recurrences, and some of it may be just again the symptoms and how vague they might be. But I've seen very few of female late recurrences. While I've seen certainly more male recurrences. So I worry more about the parallel channels, the veins I can't see, when it comes to our male patients.
Yeah.
Obviously, it's a different, it's the same, similar anatomy, but obviously it's a different disease because we're looking at.
You also have a bit of a movement, and I don't necessarily agree with this, of people that don't want coils in their ovarian vein. And so,
yes,
particularly overseas, there are people just treating this with foam and leaving it alone and not putting coils. And again, we have no long-term data that's
just a little bit. I think
tell us
we
that
put
that's
a little
okay
bit.
to do.
Do we have some more? Yeah. Okay. Yeah. I mean, I hear what you're saying, especially with things like artifact, MR and CT artifact, in somebody who has a number of coils. Obviously, we want to try to use coils that are going to minimize the artifact. But yes, I mean,
we have a question from the audience about any concerns or long-term concerns with using foam sclerotherapy in the pelvis. When you're consenting the patient, like pulmonary emboli.
I'm sorry. Repeat that again. For
any concerns, like say systemic thrombosis, pulmonary embolism, with foam sclerotherapy, and how do you consent the patient and talk to them about rates that occurs at, that sort of thing?
Yeah. That's a very good question, and it is something that I do talk to my patients about. I do tell them that, look, we're going to be causing some clots to form, and those clots actually could potentially result in initially some worsening of pain. And I do say it's a unlikely complication. And the few people that have asked me to quote a number, I've had to say I really don't know, but I do think it's less than 5%. But I don't think that's really reported, and I guess it goes probably relatively underreported here.
We almost never anticipate.
Okay, thanks. Yeah, so you probably already heard. We're just sort of, and you're seeing it on the screen. We have a pack of coils, just more central to where our sclerosing agent, the foam, went in, and we're just getting another balloon because we're going to put just one more, sort of aliquot of foam, and that's being put together now. And I guess another question I'd have for the group is, where do you like to keep your central pack of coils or mechanical? I mean, do you put coils? Do you use a plug? What would you typically be doing?
Is your question like the extent of the vein that you coil or how far cranially
Right.
you
Well,
extend it?
how close to the renal vein do you go? How close to the renal vein do you go?
We'll just go down the panel.
I go a little higher than you've gone. I go a little mid to distal gonadal vein. Just obviously staying away from the renal. And sometimes I use coils. I occasionally use the plug,
Okay.
but mostly coils.
I divide the gonadal vein into thirds and kind of do it at the intersection between the first and second third of
Looks
the
good.
coil pack.
Yeah.
Yeah, I'd take it up within a
In-
few centimeters of the gonadal vein ostium.
Okay.
Yeah,
I mean, I guess
Are you guys doing a sandwich
a few
technique as well?
a few centimeters. Like, I'm sorry. Say it again, please.
I was just asking the panel if they also do a sandwich of foam, coil foam.
I'll usually do at least 1 or 2 layers of foam and then coil a couple centimeters from the ostium.
I think there's some variability. We were in California. We were doing a lot more. It was a lot more layers to the sandwich. A lot of coils, foam coils, a lot more alternating.
I see.
Yeah.
And then just putting in maybe 2 or 3 cc's in sort of the lower volume
Lower volume of foam,
packets
coil.
of foam.
Yeah.
We have a
Small
question.
aliquots.
We have a quick question from the audience here.
I'm just wondering what's
Oh, yeah, please.
driving the interest in avoiding coils. Is that patient driven? Is it physician driven? And what's the rationale?
That's a good question. So what's driving the sort of the concern about coils? And at least my experience has been Facebook. Yeah, that's really what it is. Yeah.
We've actually had a few patients
Now we're
ask
seeing
specifically for glue as opposed to foam as well. So that's probably also.
Windsor has a question.
Yeah, not so much a question, just a comment. I look at this a little
Well-
differently. I think the gonadal vein can be a very important collateral from the pelvis. For example, if you look at patients with May Thurner, they frequently will have very robust gonadal vein. So I think I would not close the gonadal vein just in case. And if I need to close the pelvic varicosities, I'll just inject those pelvic varicosity, but going through the gonadal vein and inject very distally. So you obliterate the varicosities in around the uterus, but you leave the gonadal vein open. So if at a later point the patient needs a collateral, it's still there. So if you close it off, then you minus 1, 2 collateral from the pelvis.
So you're saying you're advocating a more peripheral occlusion to try to keep the more central limbs of that gonadal vein open as a tributary. Is that what you?
Yes, yeah,
Yeah,
that's what he was suggesting.
Yeah.
So now you're putting in another coil. Are you using another detachable coil here?
Yeah. Yeah, we're using a detachable here. It's just about ready to go in there. Yeah, I think
Is anybody plugging these instead of coils? I think we're all using coils.
I'm going as economic as possible,
Yeah.
so I only use
Pushable,
pushable coils here.
pushable nesters.
yeah, we have some pushable nesters here. I think we're gonna have to go to those in a second here because this one is is a different occlusion balloon catheter, 35 lumen, and it's just really part of it may be that I think the foam may have sort of gummed up the oh, there it is. Okay. Yeah, we're just gonna go with the pushable here. I think maybe just the lumen of the occlusion balloon catheter. Going back to the embolic, that's very interesting that some patients are coming in requesting a certain embolic, and I do get questions about, and love to hear what the panel thinks and what their experience has been. I do get questions from some patients saying, what are you going to use? Are they made of platinum? Is there going to be a lot of artifact, and what does that mean? And obviously, I tell them, look,
Yeah.
we're going to be using some sclerosing agent and some coils, and we're going to be using, there is going to be a possibility of having, some artifact. But I guess, are you getting a lot of questions like that? It sounds like probably some patients are from
Yeah, there's
what Krish said.
there's an international group on boards, Facebook, that sort of thing, that they all talk to one another.
Uh-huh.
And the one that gets thrown out against coils most commonly is nickel. People really worry about nickel.
Yes.
And people worry
Yes.
also about coil migration. Now, having said that, De Gregorio wrote a paper. It was in JVIR about 2 years ago. That Ron, Neil Kalnani, and I wrote the commentary. And I don't think there were any migrations associated with ovarian vein embolization. There were clear migrations associated with hypogastric vein coil embolization.
Yeah.
So the internal iliac vein, one, is not one I frequently treat, and two, because it doesn't have valves, so it can't reflux. Only the reservoir and the medial veins have valves, but the hypogastric vein itself, nobody is born with a valve there. So if you don't have a valve, how can it reflux? And the second thing is it's a direct shot. I mean, a coil can break off and go right to the lungs. And in fact, there was a case posted on no longer Twitter, X. Of a coil that had migraine and was treated at a hospital in London.
Interesting.
So those things kind of all together, and then put it all on social media and watch it burn.
So the groups that aren't using coils, are they just leaving a balloon up for a little while and letting the foam sit?
Nobody really describes it, right? I mean, I think what they're doing is just obliterating everything with sclerosant. Maybe they're using glue.
Yeah,
I
so
don't know.
that's very interesting. So, obviously, when I just want to ask the panel, so in this case, there are two prominent right and left gonadal veins. My approach has been is that, if they're both prominent, then we're going to treat them both. If only one of them is prominent and I can actually see the other one with a retrograde injection with a balloon, then I usually don't go ahead and select out, say, the right side if it's normal. But when it's prominent like this, I think you have to select out that right side and consider treating it. And I think the plan here for us today is to investigate it and properly treat it. But do you typically also study the iliac system?
Yeah, so
Typically go down there.
yeah, no, that's a good question. So the one thing I would say is I don't ever treat the iliac, meaning let's say there's a nivell. I don't treat the iliac at the same time as I'm doing ovarian vein reflux, because you don't want to mix your outcomes and your toxicities. You want to separate them out in time and make sure you give the patient a chance to maybe just improve with one intervention.
Right. Right.
And I don't embolize hypogastric veins anymore, just because it's a hunting expedition and I've never seen anything that really shows that works. And I will say now, I always treat both ovarians, because I had a number of patients come back after the left treatment that needed a right treatment. And it's kind of like GSV. You can get segmental reflux. You don't have to have truncal reflux. You can get segmental reflux.
Interesting. Okay. Yes, we should invest. We're just, I think we're going to get a catheter down and get into the right. But just going back, so that's interesting. So I guess that you're saying that you realize that there are other, because of the vas plexus, that there are other reservoirs, but you also realize that or understanding that if we just treat what are probably the main vessels, the main culprits, and then seeing how the patient does, and then bring them back, that I think is a very reasonable thing to do. But you're finding that the right side, even if it's normal, you're saying that it probably needs to be considered for treatment during the first session.
Yeah, what I find is, like in this case, I wouldn't be surprised if your right side is pretty beat up already. I bet you had sclerosant already going into it.
Yep.
But what I found is sometimes the cranial segment of the right isn't that bad, but then you get a microcatheter or something down a little bit further. If you're coming from the neck, you can even get a 4 or 5 French catheter down, and you'll see stasis in the parametrial plexus from that side. So I give a little bit more sclerosant there. So it doesn't usually take much, and then a couple coils, and then the right shuts down as well. But I can now think of like 5 patients that came back a few years later and had to be treated from the right as well. And the other reason I will say to treat it at the same time is with the current coverage climate for this procedure in the U.S., if I get approved once, I'm going to take that chance to just treat the right ovarian vein.
Okay. So it's interesting. So you're thinking that maybe
Yeah.
the recurrence is because we did not treat the contralateral side, even when it didn't look so bad.
Right. You had like a segmental reflux, and then, now that
Right.
you've taken out that side, the right ovarian vein becomes the dominant drainage pathway, and,
Yes.
it's already incompetent and then becomes more incompetent. Windsor had a question. How do you find the right ovarian vein? It can be challenging. A little bit easier from the neck than the groin, for sure. But what are your guys' thoughts on that?
Yeah, there it is.
Kind of
Yeah,
like
I mean,
what,
it just, yeah, I'll go ahead, please.
yeah, kind of like what you guys are doing right now is basically getting right underneath that right renal vein and hunting around with your glide catheter.
Yeah. Yeah, that's always been.
You always use a glide cath?
It can be hard. I mean, there's a couple times from the neck I've had to use a Sim 1, even a Sim 2 if it's a big enough cava, an Ansel 2, Ansel 3, and you vary the amount of curve you have. It just depends. You see, it's already beat up.
Yeah. I mean, this is obviously a decent sized one, but with a small one, I agree they can be pretty tough, and I think just like was mentioned. Yeah, yeah, yeah. Well, let's see. Yeah, why don't we at least just do a run here, and then we can take a look and see. What does the group think?
I think
It's just like you were saying. It's beat up and it's a smaller caliber. We're just gonna do a little run here, and see what that looks like. There's some parallel collaterals there too, but there isn't really much flow back down towards the pelvis anymore. What does the group think?
I think I might just coil this, and then be done.
Yeah, I think we'll put a coil in it at the very least. Yeah, I think we could put one here and maybe just one up a little higher, and I think we should be good. Yeah. Is the panel happy with that?
Yep.
Yes.
Good.
We'll put 2 sets of coils here. 2 sites, probably right here, maybe a bit lower, and then just sort of on the other side, not around 2, 3. Yeah. Okay. Is anybody in the panel doing routinely the iliac interrogation? For both sides. Routinely.
You're talking
Because
about internal iliac?
in my experience, I have not. Yeah, I'm talking about the internal iliac. In my experience, I have not. And when I have done the iliac vein, it's usually just without a balloon and just trying to get as deep as possible, and then trying to get as peripheral as possible, and then go ahead and putting in the STS, just foam there. But I'm just wondering, what the group thinks about that. And again, getting back to what was said earlier regarding being a if we're going to go ahead and treat that, is that going to cause problems in terms of flow from here we go. Good.
I don't routinely look at the
pushing
internal
that in.
iliacs. I think I agree with Kush about not looking for extra problems
One
that
more
may
high.
muddy the waters about what your outcome is. I think patient has symptoms and you have clear pathology to treat, and I think if it doesn't work out, then it's time to think a little bit more.
Yeah, the issue I've run into the last time I
great.
treated a hypogastric was
Uh-huh.
as the bladder fills, you start seeing other things. And so there was this one time I'm like, it was like whack-a-mole, kept popping up. And then I had the patient void. We had emptied the bladder on the table, and all those, quote, varicosities went away.
No, look, I do think it's just like you said. It's not, you know, it's just a completely, you're just opening up this sort of whole bag of worms of, you know, whether it needs to be treated, how far do you have to go, how much, the endpoint becomes sort of very, very difficult to sort of assess. But that's very interesting that they just went away after the bladder was released. Interesting.
There's a question, is the
Okay.
approach any different
Yes.
between premenopausal versus postmenopausal women?
I have not, you know, I changed my approach. I mean, I do think that I do ask the, you know, the GYN doctors if they feel that they've done enough with their medical therapy, with hormonal therapy, and if they feel comfortable with that, then you know, I think that, you know, I offer them the you know, the sclerosis and embolization. You know, there are some patients that come in, I find, and I can't really tell you whether they're pre or postmenopausal, that have a particular symptom that's been really nagging them. And if I really feel that that is and let's say like we had one patient who had really very significant left lower quadrant, you know, pain that she had had for many years, and it was really sort of episodic and good standing. And so on those patients, you know, I tell them, look, you know, we can do this, and we can really make this better. But otherwise, I try to have them do the hormonal therapy first. If that doesn't work over, say, 4 or 6 months, like in this case, then we'll go ahead and offer them the embolization. Okay, I think we're in really pretty good shape. Thank you. And I want to
case.
thank the panel. Is there any other comments from the audience or from the panel?
We have one comment or question. 1 second.
Oh yeah, please.
Come into the mic.
Thank you. Very nice presentation. Very nice case. But I have a few questions. First of all, do you have experience of reflux just only right gonadal vein with intact of left gonadal vein?
Isolated right ovarian reflux. Have you seen it?
I have not. It's very interesting.
Isolated, right?
I have not either.
I have not. Obviously, I think we've all seen obviously just a prominent left
Yeah.
and
So-
normal
so-
looking right.
So you want to say that it should be only left or both? No, only right, yes?
Well, I mean, you're going to look at both,
J-
and you might. I don't think you'll find an isolated right ovarian reflux. If anybody in the audience has seen that case, please speak up. But you're going to look at both.
Yeah, but I have had some experience of some patients with just on enlargement of right gonadal veins without enlargement of left gonadal veins. That's why I'm asking. And second question is, this patient has a varicose veins on the legs?
Are there any varicosities on the legs?
So she does not, and she also does not have any vulvar, you know, varicosities. You know, so that is something, you know, we look for, and she did not have any other varicosities, just this, and I really felt that her pain symptomatology was likely related to this, and obviously after failing the hormonal therapy, we thought this was best for her.
Thank you.
But thank you.
Thank you. Excellent case.
All right, thanks everybody. See you a bit later.
Okay, take care.